Yep.
Yeah, recording. Yay!
Yay.
All right, talk quickly.
Sure.
All right.
All right. So let's see. Where do we want to start?
You want to introduce yourself and backgrounds, and then we can kind of, maybe you can go first on kind of talking about how you discuss pain with patients, or just kind of your approach to and pain models and stuff.
Yeah. So for those listening, I don't know if I'm showing up on video or not. Taylor Weglicki. I'm a physical therapist, both in day job and with Complete Human Performance. Been out of school now, I guess, 5.5 years. Worked in a variety of settings: outpatient orthopedic, pediatric, geriatric, skilled nursing. It's been kind of nice. I've been able to see a whole wide range of stuff, but recently, both kind of in, I guess, with you, Kelly, but just kind of researching and working on pain stuff, because it's a major problem, especially in a state like Mississippi, where I am currently. And just the general public at large is very poorly understood. There's just a huge lack of education, I think. So I guess just kind of talking about how I educate my patient load. Well, let's do this. Should allow you to introduce yourself first, too.
Okay, hold on.
As the dogs enter the room.
All right. Oh. All right, let's try this. Sorry.
No, you're fine.
All right. Just relocating.
Yeah.
Okay, so we'll cut that part out, and then so those listening, I am Kelly. Kelly Bruno. I am a physician trained primarily in anesthesiology, and then currently doing a pain medicine fellowship and research fellowship in pain medicine at the University of San Diego. I think my interest in pain is because I grew up as an amputee, and just, hearing about people who deal with amputations later in life and how much pain they have. It's been an area of interest for me for a long time. And I think the more we know about it, the better, we are equipped to treat patients who have a variety of painful conditions, both people that are active, like athletes, and people who just want to, have a higher quality of life.
All right. So then I guess moving on and starting with kind of how we discuss it with patients. I mean, you want me to take it from there?
Yeah.
Sure. Okay. So my patient caseload currently, I am in a small town in Mississippi at a rural hospital. So the city of itself is around 4,000 to 5,000 people. And we see folks in a radius of probably 80 miles from the hospital itself. We serve a nursing home, a swing bed facility, and then also outpatient, which is primarily what I see. We right now have actually had a huge influx in the past 2 months from a lot of the local pain clinics, and has made it kind of interesting, because what I'm finding is I get one of two types of pain patients. I know that's a big generalization, but there are ones who truly want to get better, and then there are ones who just want to talk about it and so kind of live in their misery to a degree. Both kind of have their pros and cons as far as treating. The ones who not are really motivated to get better are definitely a bigger struggle for me as a clinician, just because it's hard, especially with, unfortunately, the education level of a lot of these folks, getting them to understand like what role the brain plays in interpreting pain can be tricky, to say the least.
Yes.
So, and I know, Kelly, this is something that you've been pulling up a lot more in your research.
Yeah. So that's, I think just understanding that kind of body and mind connection, and I think when you start considering pain as kind of as a full body experience and trying to apply, I've done a lot of reading in the topic, especially for kind of the application to managing pain for patients in the clinic, you start looking at these different pain models, and the kind of, I think the one that they teach us the most in our medical training is just the gate theory and the concept of kind of, opening the gate and having kind of a balance between the different, the perception of pain, and that those signals going to the brain, and the body can kind of close that gate off and stop pain. And at some point, for some people, it gets overwhelmed and it kind of leads to this chronic pain state. And, as I start to apply it and look into it further, it's amazing to me just how much deeper it goes than that, and just at how many levels that pain exists. If you put your hand in a fire, that's kind of like the whole concept, like Descartes, who's kind of like the founder of pain, the first person that really kind of identified pain and the pain processing pathway. That's kind of the picture they use, is somebody, I think it was the foot in a fire, and just that reflex of removing it and having that signal basically go from your hand to your brain, telling you, hey, that's a bad idea. It seems so simple when you look at it that way. And then, you just, as we learn more, it's just amazing how quickly you realize that there is so much more involved, and there's, things happening at the level, the peripheral level, the level of the hand. There's things happening in the spinal cord. There's things happening in the brain. And then there's that whole component of kind of the psychological response to pain. And as you said, Taylor, that concept of some people, want to get better, and some people, I don't want to say they don't want to get better. They just, they're kind of, there's that barrier to really, I think, being committed to feeling better. And so managing those two things, and I think both the physiology and the psychology of pain is kind of why I think some people have effective pain treatments and some people struggle with it.
Yeah. And that's, along those same lines, you talk about, I hate to classify people as don't want to get better, because that sounds really defeatist, but education is rapidly becoming like one of the fastest ways I've noticed clinical improvements in folks. When you kind of can explain like why they hurt, all of a sudden they can name it. There's a qualification of what it is, and it's all of a sudden not quite so scary. I think the fear of the unknown is almost the biggest thing there with a lot of the pain. It's funny too that you brought up the gate control theory. That was actually the first thing we were taught regarding pain in PT school as well. And I don't know if that's just was the predominant theory at the time.
Well, I think it still is to a major extent. It's funny because that theory was proposed years ago, but and I think everything we have now is built on that theory. There were a number of theories that led up to the gate control theory. Melzack presenting it, but then since then it seems like regardless of what type of pain I'm looking at research for, that's the predominant kind of reference point that everyone goes back to. So whether it's neuropathic pain, like an osteoarthritic pain, neuropathic pain, phantom limb pain, like it doesn't really seem to matter what ischemic pain, it doesn't matter what kind of pain it is. It back to that. And then I think we've built a lot on that since then. I think there's a lot of research in looking at inflammatory pathways that I think, hopefully, especially with this opioid epidemic that I'm sure, Taylor, you face a lot these days in the clinical world, there are therapies, hopefully, that we can start targeting, those kind of pathways in a different way without the side effects of opioid medications.
Yeah, and to give you an idea, in regards to opioid medications, in Mississippi alone, every man, woman, and child can get, I believe, a month's worth based on how many prescriptions are gone in a year.
Wow.
It's heavy here. And that's, even with, I've spoken with a couple of the pain doctors, I believe UC Boulder came out with a study late 2016 or early this year, talking about how a rat study, but there's some negative connotation with the opioids and how the body interprets pain, and actually can make some of the pain receptors, I guess, intensify the signal. And just something, granted, it's a rat model and it's not directly applicable always to humans, but that should be enough, I think, to make us think twice about, like, why are we just overloading folks with these medications? It's sad.
Well, and it's interesting too, because opioids really were developed primarily, for that post-operative pain period, that period where you have acute pain. You fall and break your ankle, have an athletic injury, you have surgery. It had a very discrete period of time that it was supposed to be effective for, and that's kind of why people prescribed them. And then and it's really actually never been shown to improve, in any long-term studies, back pain or any of these reasons that we're prescribing it now. And so I think that's why I'm so interested in other therapies, because I think that they honestly can be so much more effective, and people can be so much more active with other options, especially I think with the athletic community, people that these are, I think, generally people that don't want the side effects of the opioids, like constipation, somnolence, just a lot of those things that kind of have that negative effects. And I think there's a negative connotation with them. A lot of people don't are hesitant to kind of go that route, and I understand it. So
the fear of addiction is a big one I hear a lot of too. Nobody wants to get hooked.
Unfortunately, especially in this community, a lot of times when you're working with, high-level athletes or, recreational athletes who, I think they tend to have kind of a predisposition for that kind of addictive personality.
Absolutely.
That can be concerning, I think, to a lot of people. So anyway.
Yeah. And it's, coming back to kind of like pain models and stuff, once you kind of remove that out of the equation and you add in that education piece, I mean, sometimes I've had, just clinically, I mean, this is jumping topics just a little bit, but you bring in like, hey, this is what pain is. This is what pain does. This is how your body's interpreting what's going on. And it's like a light bulb goes off. And I'm like, oh, so what is the pain medication doing then?
Right.
It's like, well, it's kind of numbing this and changing, and granted, I'm not a medical doctor, so my pathway understanding is limited to what I learned in college, but and then they're armed with better questions. They go back to their doctors and they're like, hey, why am I getting these medications? Why am I not getting better despite the fact that I've been on this pain medication? And it is prompting some really neat stuff, both in manual therapies and a lot of some of the modalities. I know dry needling right now is still nascent and learning quite a bit, but there's been some fun research, I guess, and anecdotal stuff, at least, that I've seen that's been pretty promising.
That's great. I think if some of these medication therapies, are kind of temporizing until you can get maybe a therapy that works, long term. So whether it's dry needling, or we do a lot of ultrasound guided injections at my facility, which they're doing a lot of research in protein rich plasma and stem cell injections into the shoulder and knees, with really good case report responses. So I think you can get people, kind of make people aware of those options, especially for people that want to stay active and have a hard time doing it. I think, we learn a lot about the pathophysiology of pain, but at the end of the day, that is only so useful. I think at the end of the day, how do we translate that into, improved therapies for better pain control?
Yeah.
We do it.
So so with the ultrasound guided injection, could you go into a little bit more what that entails? Because I know I have seen it before, but I don't know if everybody else would
Yeah,
quite understand that one.
That's a good point. Yeah, so we use an ultrasound machine, basically the same device, that people use to look at like a baby, during development, to the fetus during development. So same idea. And we actually can look inside either the knee joint or the shoulder joint, and actually some of the different locations on the head, stomach, back, and actually place either, usually we do like a steroid, that's kind of the most common, but we either place a steroid or some local anesthetic, or then, like I said, the PRP, the protein rich plasma, or stem cell, which is kind of newer therapies, and we actually inject that into that space to kind of coat those nerves in that area and try to reduce the pain signaling to the brain, by reducing some of the inflammation in that area, say for like a bicep tendonitis or a rotator cuff injury, or patellar tendonitis, or meniscal tear, and so it kind of reduces the inflammation in that area, helps to rebuild that area, and then also causes some pain relief from like the local anesthetic. And so that's the goal. And people are going 6 months between injections, and actually have very good kind of return of function afterwards. And so there's other ideas, other therapies that I think people know a lot less about, unless they end up in a pain clinic.
Yeah. And that's right now, I mean, it feels like there's not a lot of good resources on, well, maybe that's something we need to work on. That's something that, people really need to be able to see, because you Google pain and it's so, I don't know, overwhelming to say the least, because you anybody that can have a YouTube channel has talked about it to this degree. And it's, I mean, even from a PT standpoint, there's a large portion of my profession right now that is still really stuck on kind of the postural structural model. Everything's a mechanical pain. If it hurts, it's because it's not mobile enough, kind of thing. And it's frustrating, because on some degrees, like that might be part of the problem, but I think it's the same thing. Like, oh, I've got tingling in my hand, and everybody kind of is quick to jump to carpal tunnel. Well, what about the shoulder? What about the neck? Like, I mean,
Right.
you can't just jump to the first thing. And I feel, you get a lot of these people, like you said, with these chronic back pains or bicipital tendonitis and stuff. And I think that having a pain clinic that understands that and can actually say, hey, we're going to do this injection just to kind of stop the localized hurt, and then you're going to go to see this other person so we can figure out where it's coming from.
Right.
Because it could be a work-related injury, could be who knows?
Yeah, and I think if you can identify then the problem, and work with someone who can get you stronger or whatever is causing that inflammation, I think I would agree. That's the goal at the end of the day. But I think using these therapies in the meantime to get to that point, opioids and a lot of the kind of medication management, NSAIDs are good, non-steroidal anti-inflammatories are good, because they do have an anti-inflammatory effect, and that's really important. But, I think just like, opioids cover up the pain in my head. That's how I think about it, but they don't really treat the underlying issue.
Yeah. And then you run the risk of doing like I did in high school and college sports, and well, it hurts to run, so I'm going to take some ibuprofen and then go run, and that'll make it better.
Right.
So because that's the most reasonable thing to do, is completely ignore it with NSAIDs.
Right. Exactly. Yeah. Well,
you can't help it. So I've always been curious. You said growing up as an amputee and stuff, have you had to deal with some of the phantom limb, like pain syndrome type things?
So I've been lucky, just because my amputation was so early in life. I didn't really have I don't think my body ever really recognized my foot. And so I really haven't had that kind of phantom pain experience or that phantom limb experience that people describe. But I do, so there's like different types of pain that you can have. So like the phantom limb or the phantom sensations. But then there's, more like neuroma related pain, and that can cause some of the phantom limb sensations as well. So I've had plenty of the neuroma type pain, which is, I think, easier to treat possibly, but because it's a little more localized, but
Sure.
It's pretty debilitating on its own. So I couldn't describe the phantom sensation to you, but I can, neuropathic pain, I have a very good understanding of, and it's, it's its own beast.
Sure.
Hence
So
my research.
I've actually got a couple of amputees and as clients right now, there's patients, I should say. And one thing, and this is just questioning, but how much of it, one guy I know for sure has one because of the residual limb wasn't really operated on as cleanly as it could have been. So there's a lot of leftover tissue at the end of where his tibia is. So how much of that do you think may stem from like that portion of the tissue wasn't originally like a weight bearing surface?
Right.
And so like maybe now like within that prosthesis, that's what's causing some of the problems.
It's hard to say. I mean, so I've like the research that is out there, it's variable, and I don't think, there's still so little understanding of it, but I don't know, there's been no association between the type of surgery or the quality of surgery that you have and the rate of phantom limb pain. The biggest predictors of phantom limb pain is actually pain before the amputation. So depending on how why the amputation occurred, and then if there was any pain beforehand.
Oh, wow.
Before the amputation occurred itself. And then the age of the person at which the amputation occurs is another risk factor. So older people have a higher chance of having phantom limb pain. And then the third risk factor that they have identified as significant is whether or not you have one or two amputations. So if you have bilateral amputation, you have a higher risk of having phantom limb pain. And I think that's kind of where the mirror therapy comes in. By Ramakant, actually here. He's actually a professor at the University of California, San Diego.
Oh, wow.
Yeah. I need to like figure out how to get into his lab and be like, hi, just need to meet you just once.
Yeah.
That has really changed, I think, a lot of the understanding and the research within phantom limb pain. But I think that's part of, that the bilateral amputation kind of hits home with that, because it's, I think having one limb to at least identify with still makes a big difference in how you do and whether or not you have those phantom sensations. But I think a big part of it, and the research I'm going to do is neuromodulation, and looking at like either peripheral or central neuromodulation. Which is kind of a big word, but basically just means, changing the nerves and the nerve sensation. But that the changes in the brain, I think, are what is kind of the biggest contributor to phantom limb pain, is really just that brain, that suddenly this part isn't there, and there's this area of the brain that used to like, all that information went to, and now there's no information going to that part of the brain. And so the brain kind of doesn't know what to do. This is not normal. And so it has to remap somehow, and that doesn't always happen correctly.
Yeah, absolutely. And so just to backtrack just slightly, you said the mirror therapy. For those who are not familiar, mirrors are basically set up in relation to the amputated side, so it looks like you have an actual limb still there. From a physical therapy standpoint, we'll then like kind of work the working leg through range of motion, but the, I guess, patent limb, if you will, and kind of just talk to you about how, and this is rudimentary, I guess. I have not been super well educated in mirror therapy, so please don't crucify me on this one. But then, just kind of working and talking about, hey, look, it's okay. You can tell yourself it's fine. Everything's moving okay. And it gets more complex than that, but that's the basics of what I've used it for phantom stuff, and then also for like a complex regional pain syndrome.
Yeah, I think those are kind of the two indications for it.
Yeah. And it's hard to build a mirror box for anybody that's wondering. I'm not the most handy person. It really is.
I just figured that they like were there available. I never really thought about the having the equipment.
Yeah. Well, I mean,
stand in front of a mirror, but I guess it doesn't work that way.
No. In a well-funded clinic, yeah, maybe you have them, but in a lot of these more rural places, we build a lot of our stuff from scratch.
Interesting.
Yeah. I mean, you got to do what you got to do if you want to provide the right therapy. So get creative. All right. I'm not sure I got much else I can say on the topic right now. I'm kind of brain dead. I apologize.
Kind of the generals of I think the current understanding of pain. And I think one thing I did want to say, because I think this is one issue that we face a lot in the fitness industry is this reliance or this a lot of people, like you said before, Taylor, that a lot of that the kind of current understanding is more of this, postural type framework. And even the biopsychosocial model, I think is also, commented on pretty frequently as well. And I think just realizing that there's so much more to it than that is just really important for both clients and coaches to understand, and that it's not. It would be nice if it was as simple as, what is it, the BPS and the postural model. What's that?
PS, postural structural.
All right. Yes. But it's just, it really isn't that, if it was that simple, there would be a lot fewer people with pain. And I think one thing that, especially for me, like I have one leg, at the end of the day, I have an imbalance. Like I will never be symmetrical. I will always be imbalanced. But I don't generally have chronic pain. I don't have back pain. I don't have, a lot of these, hip pain, or even though, I squat, I run, I deadlift, I bench, I do a lot of those movements. And so in my head, I know that there is more to it than just being kind of asymmetrical, because there are plenty of people that have asymmetries who don't have pain.
Sure. And I think that's a big driving point too, is the general human is going to be asymmetrical. I mean, nobody has perfect symmetry. Right. But the question is whether or not it's symptomatic. I mean, I think if you're asymmetrical when it's directly causing, if you have a scoliosis causing your back pain, yeah, I mean, that might be something worth addressing. But just because your shoulders are a little bit internally rotated doesn't necessarily mean that's causing everything that's wrong with you.
Right.
And it's that clinical stuff, I think, is as much an art as it is a science. And then being able to balance that, you can't read it in a study. You can't find it on PubMed and just suddenly be able to apply it. I mean, there's a practice to it, and that's why it's a clinical practice.
Exactly. That's why you have the practice of medicine.
Yeah, exactly. And
it's not. Ongoing.
Like you talk about everybody being asymmetrical, just because, I mean, my blood pressure just started going up because the amount of times I've been approached in a gym and had somebody go, "Hey, I think my glute med is weak." I'm like, "Wow, you run, you're probably okay." I mean,
right. Yeah.
I mean, and to be able to, folks try to isolate stuff like that in such a vacuum. It's just not. The human body is not that easily defined.
Exactly. That's a good way to put it. I like that. Yeah.
So, and like you said, models. It's a model. It's not a law. It's not not even really true scientific theory at this point. It's just kind of like, hey, this is a framework.
Yeah.
We think this is a reason why stuff happens. I mean, I guess gait control was actually the rest of it is just kind of theoretical models at this point. Nobody really has a true understanding. Brain's too complex, body's too complex to know it for 100% certainty.
Yeah, I mean, and I think that's what I'm so fascinated with the research that we're doing here at UCSD, is that we are just learning so much about, inflammation and the inflammatory process that is involved in pain, and just the number of factors that are involved, and how all these changes occur and how they're all interrelated, that I think we know a lot more than we used to, and we're going to keep learning. I think, but I think, like you said, it's a framework. I could just throw out like names of things that people have never heard of before that I just learned about in the last 2 months since I started this research. And these are like very high level scientific studies. We are doing neuroimaging of the brain to figure out, what pathways are affected. And it's fascinating
Cool.
stuff. But I think that makes me just realize how much of a framework it is. And that when I hear people say that it's a very, that this is the problem right here, just I think being aware that there may be more to it than that.
Sure. And I think the whole idea of a framework might be a useful topic for another conversation. Using that as a jumping off point, if you will, but not your end all be all.
Perfect. That's a great idea.
All right.
Well, I think that's good for today.
Yeah.
We have a lot to talk about in the future.
All right. Thanks for talking, Kelly. I appreciate it.
Thank you, Taylor. All right. Catch you later.
Bye.